and what they have learned in the past almost 2 years of this pandemic. As a former student from the School of Public Health, it is an honor to join Dr. Lushniak in moderating today's session. Dr. Boris Lushniak is the Dean and a professor of the University of Maryland School of Public Health and former Deputy Surgeon General and Acting Surgeon General of the United States. Dr. Lushniak, I'm really looking forward to moderating today's session with you. And before I provide an overview of the objectives for today and introduce our panelists, I would love for you to share a bit about why it is important for you to be a part of today's session. Welcome, Dr. Lushniak.
Thank you so much, Kande, and thank you for being the co-host today. I keep saying tonight it's all in your hands, and we have a great panel here tonight that Kande will be shortly describing and introducing to us, as well as the objectives of this evening. To everybody who's joining us here tonight, thank you for joining us. There's a lot of information to share, and first I'd like to thank Angela and the Alumni Association for welcoming the School of Public Health and having us offer this session, right? This was a few weeks of work, us putting everybody together, and hopefully a informative session over the next hour. In addition, I'd like to thank the University of Maryland School of Public Health Assistant Dean for Development, Jennifer Schwartz, for connecting our school with the Campus Alumni Association, Go Terps, and the University of Maryland School of Public Health Chief of Staff, Aaron McClure, for spearheading this and the previous campus-wide COVID-19 sessions that we've had. I'd like to mention that this really is a continuation. This series is sort of built upon a previous series of COVID-19 information sessions that the School of Public Health has hosted for campus employees and extended it to the University System of Maryland employees in partnership with University Human Resources. And it was sparked by a recognition that our community was seeking more information to support knowledge sharing and decrease worries and anxiety from the unknowns. As Angela already mentioned, we do encourage this to be a conversation as much as Zoom allows. So if you do have questions, comments, other things, we'll be monitoring the chat space, both Kande and I and Angela, and hopefully get to your questions as the evening goes on. So thank you again for being here, and thanks for everybody who played a role in putting all this together. And now back to you, Kande.
All right, before I introduce our panelists, I'm going to quickly go over the objectives for today and the agenda. The 4 objectives for today's session are to increase knowledge on the current state of the COVID-19 pandemic, to grow your health literacy and learn where to find accurate information and how to understand this information, to learn how to translate information to make educated decisions that support participating in activities safely, and to understand how to listen to and keep communicating with one another across differing opinions to keep our communities safe, healthy, and thriving. In terms of our agenda, we will first start with the panelist introductions, then we will jump right into the panel Q&A, after which we will have closing remarks from all of our panelists. So without further ado, I am pleased to welcome all of our expert panelists who join us from the University of Maryland School of Public Health, located on the flagship Maryland campus in College Park. I would like to welcome Dr. Cynthia Bauer, Endowed Chair and Director of the Harwood Center for Health Literacy, Dr. Jessica Fish, Assistant Professor in the Department of Family Science and the Deputy Director for Research and Evaluation at the University of Maryland Prevention Research Center, and Dr. Stephen Thomas, Professor in the Department of Health Policy and Management and the Director of the Maryland Center for Health Equity. Welcome, panelists. I would love for you to share a 1 to 2 minute summary of your COVID-19 related work. And let's start with Dr. Bauer, please.
Thank you so much, Kande, and I'm extremely excited to be here with all of my great colleagues. I was just reflecting back that Dr. Lushniak and I were standing on a stage about 1.5 years ago when this new virus that we were hearing about was starting to really make the headlines, and people had a lot of questions. So he's right, we've been at this business of answering questions a long time. So our COVID work has really encompassed these public presentations over the last 1.5 years, almost 2 years, the project that you referenced that we're doing with the local health improvement coalitions and a network of LGBTQ serving organizations that Dr. Fish is going to talk about. And that's funded through our Prevention Research Center and CDC. And then another project that we recently launched called Advancing Health Literacy, which is with the city of Frederick, Maryland. And for the next 2 years, we're going to be partnering with a number of organizations in Frederick and their community health workers to not only get out COVID information, which of course is extremely important, but also really build health literacy infrastructure in the city of Frederick so that 2 years from now, the city of Frederick will be much more prepared than they are now to tackle whatever the next public health challenge is, right? Because we know COVID is just going to be one in an ongoing series. So I'm very happy to be here to talk about all those things with everyone tonight. Thanks.
Thanks, Dr. Bauer. Dr. Fish?
Yes, hello and good evening, everyone. So the work that I've been doing in COVID kind of falls into two camps. The first is more social epidemiological or descriptive and trying to understand and identify the social and mental health consequences of the pandemic, particularly for LGBTQ youth and young adults. For example, I have a study where we conducted early on in the pandemic of LGBTQ young people that showed how stay-at-home orders early in the pandemic, although quite necessary, left many LGBT youth feeling vulnerable and struggling with their mental health, particularly when they were home with family who were unaffirming or rejecting of their sexual orientation or gender identity. I've also been working with several colleagues in sociology at the University of Maryland on a longitudinal study that is now in its 5th wave and captures the social consequences of the pandemic for LGBTQ and other marginalized groups. The second camp of my work has been more applied and is really related to the work that I've been doing with Dr. Bauer and our team around vaccine uptake. And I've been working within the University of Maryland Prevention Research Center with this COVID supplement that's funded by the CDC to increase vaccine uptake among LGBTQ communities. And to do this work, we partnered with a national organization named Centerlink, which provides training and technical assistance to over 280 local LGBTQ community centers around the country. And we worked with them starting this past summer and conducted focus groups to understand what LGBTQ centers need to help communicate up-to-date vaccine information, dispel misinformation, and encourage vaccine uptake in LGBTQ communities around the country. And since those focus groups, we developed a number of tools and disseminated and implemented various toolkits to try and help them implement these types of strategies in their centers.
Thank you, Dr. Fish. Dr. Thomas?
Hey, Condi, thank you so much. What a wonderful time to be here this evening with you all. I think the theme in our Center for Health Equity is building bridges, building trust, building healthy communities. I'm going to share my 2 minutes with our community partners, and I'm going to cross my fingers there and say to Caitlin, hey, Caitlin, let's go to videotape. Let's take this group out into the neighborhood. Barbershop is a sacred space for the kinds of conversations we need to have to move people from vaccine hesitancy to vaccine confidence.
Well, when Dr. T first came to me, he made me realize that we are more than just barbers because of the relationships that we have with our clients. Getting the right information to them from behind my chair is a definite way of giving back, is helping the community.
Mike sent me a flyer. He said, hey, Dr. T, this is information being distributed in our communities. And the flyer said, COVID's a hoax. Don't take the vaccine. Our communities were marinating in misinformation.
I tell them, I can understand your concerns. Don't disarm yourself. Do your research and make a decision that's going to benefit the well-being of your family and the other loved ones around you.
And on May 17th, in Mike's shop, we did the first barbershop vaccine clinic, needles in arms, anywhere in the state of Maryland.
It was just awesome to see the people coming in and rolling up their sleeve and taking the position to be vaccinated. I was excited.
And now I think the barbershop and salon in the Black community is recognized as a legitimate place for engaging a population in health promotion, disease prevention. So I've been ecstatic. And if you can give a life-saving injection of a vaccine in a barbershop, why can't we give the flu shot there? Why can't we give the diabetes test there? Why can't we do tele-wellness there? That's the vision. Okay, Caitlin. So that's my question to you, scholars. why can't we bring a whole range of services that these communities need out of the clinic, out of the hospital, and actually in to settings that they already trust? And that's what we were doing today in Temple Hills, Maryland. And so at the end of the day, the last report, Boris, we had 15 people vaccinated in our Temple Hills shop and another 16 people vaccinated in our Baltimore City shop. And we did them both on the same day. So something positive's happening out there. And Cynthia, I hope that we can really make the pivot and not abandon these community partners that we've gained over the course of the pandemic. And with that, I'll turn the floor back over to Condi.
Thank you, Dr. Thomas. Now, Dr. Lushniak will get us started with a 2 to 3 minute "Where Are We Now" update on COVID-19, and then with the Q&A section.
Thank you, Conde, and we'll begin the Q&A shortly, but I sort of thought it important that we reflect on not only where we're at this moment in time, but where we've been. Believe it or not, today is day number 684. We sometimes forget that this is now, 20 months that we've been into this, a year and a half. We kind of get lost in all this. But in essence, for 684 days, something about COVID has been in the news each and every one of those times. And sometimes the news was devastating. Sometimes it was encouraging and hopeful. Sometimes it was convincing the world. Sometimes it was looking at the issues presented in front of us, inequities, availability of care, resources, the world of vaccines and the intricacies associated with decision-making in the midst of a crisis like this. It's obviously a global event. So the issues are not just within the state of Maryland, within our counties, within our nation. These events are within the globe itself. Where are we now? Well, over these 684 days, with the ups and downs, it's never been great news because we sometimes forget that in the midst of all this, worldwide, we've had over 5 million people die from COVID-19. Here in the United States, as of today, over 764,000. So if you do the math, that's 1,000 people a day in the United States over these 684 days since this became part of the news. That began where? Began way across the ocean. It was all over there. And Cynthia did a good job in terms of reflecting. At one time, we were on the stage at the Stamps Student Union talking to a crowd. Nobody was masked. Nobody was vaccinated. We were talking about something that was occurring over there. And yet our warnings as public health people is brace yourselves. We can't predict the future, but it's going to be over here. Worldwide, 253 million people have had COVID-19. Here in the United States, 47 million people have had COVID-19. In the midst of all this, we've had extreme success with what? With a vaccine development project. Not one that's only been around for 684 days, right? The technology's been around for a good decade plus, right? In terms of determining whether we can make vaccines using newer technologies. That has now proved to be successful. Worldwide, 7.4 billion doses have been administered. Here in the United States, 440 million doses of vaccine administered already. And what are we at now? We're at a point where we realize vaccines, never ever 100% perfect, but in essence, the proof is in the numbers. The proof are in the data, right? And the data shows decrease of number of people who develop COVID-19, not down to zero, but it is protective. Even for individuals who develop COVID-19, the protective factor is what? Decrease of hospitalizations and decrease of deaths. So what we have is an incredible move forward. Yes, we continue on public health recommendations based upon what's going on in our communities. Are we masked? Well, we still remain masked on the campus of the University of Maryland College Park when we're indoors. Are we vaccinated as a community? Today, President Pines at a meeting in front of the deans was describing 99.8% of individuals who have been vaccinated or who are taking the COVID testing on a regular basis, right? So we have that ability to say that things can change towards a positive. And yet the inequities here and now still exist. We know there are communities that still have problems either accessing the vaccine or accepting the vaccines. We know this is not only within the United States, but worldwide. Africa as a continent, under-vaccinated to an extreme. The poor nations, under-vaccinated to an extreme. Eastern and Central Europe, under-vaccinated. Where are we heading is the next big question. And where are we heading, it's always difficult to say because the parameters keep changing. Throughout this whole time period of 684 days, I used to say, well, look at Europe, and Europe is about 2 to 4 weeks ahead of what's been happening here. And yet each and every day, if there is an optimism here, is we are increasing the number of vaccinated individuals each and every day. That's not regressing, that is progressing. We're seeing another surge in parts of Europe right now. Does that mean we're going to get hit with a surge? Well, once again, we're seeing that COVID-19 has turned into a disease of the unvaccinated at this point. We're also obviously in a different scenario compared to the rest of the world. We're now boosting individuals while the other parts of the world are waiting for their first doses. Is that the right thing to be doing or the wrong thing to be doing? Well, we have the vaccine. We're pushing ahead on that. Began vaccinating the pediatric population, right? 5 and older getting vaccinated. So the reality is that we're in, I believe, a better place than we've been before. Where we're heading, it's unclear, but one has to have that level of optimism because we are more vaccinated than we've been before and more in tune with what's going on in our communities. So in that simple 2 to 3 minute rendition of what's been happening, this leads us to our first question, and specifically to our dear panel members. And we'll begin with Dr. Bauer, Dr. Fish, and Dr. Thomas, doing it in alphabetical order. What have been the successes in the work you're doing to address the challenges related to COVID-19?
So of course you had to ask me the hardest question first.
Absolutely.
Because I think that the vaccine as an innovation in the response has been far more successful and effective than the communication piece of this. And I think we were just before we started this event, we were talking about how the Surgeon General has actually now issued a report and a toolkit and recommendations on how to address health and misinformation. So it's risen to that level of significance in our society because there are so many people who are being exposed to not only the virus, but to a lot of information that is misleading them about what might be in their best interest. And so I think our successes have been hard won and modest. I think we have had some success in sensitizing people to how clear and direct the messages have to be. So the project that Conde is on and that Dr. Fish and I both referenced, we've come up with this Hot Topics product that we've been distributing, with breaking news. And what we've been trying to do is give people what my former CDC colleagues would talk about as the option for a bite snack meal approach to information, right? So if you just need, accurate headline that will ground you in what the breaking news is, that we do that, but then we give you a little bit more information and then we give you some talking points and some messages that you can share with others. I can't say that our Hot Topics is penetrated, to as many people. We don't have the distribution that we would like, but anybody on this event today is more than welcome to be a Hot Topic subscriber. but we're really trying to, help people, give people some grounding in those breaking headlines and point them to those accurate sources of information. So again, a modest success, but I think we're starting to kind of establish that it is important to pay attention to the information that you consume, and that being exposed to bad information is just as important as being exposed to the virus itself.
Great, thank you so much, Cynthia. And we're going to go with first names here. So Dr. Fish, you know you're a doctor, a PhD. Dr. Thomas, you also are a doctor, PhD. I go by Boris. My pronouns are he, his, him. And let's keep it informal. So enough with the doctoring stuff, right? Jessica, are you okay with Jessica?
Preferably, yes.
Okay, go for it, Jessica. What's the successes in some of the work that you've been addressing?
Sure. I think this dovetails with some of the comments that Cynthia was raising. These are hard-won fights. I think one of the things that we're learning is the benefits of going to trusted sources in the community. So a lot of the work that we've been doing in Maryland, we've been doing with local health improvement coalitions within counties throughout the state that have established reputations and relationships in their local communities for our LGBTQ project. We are partnering with LGBTQ community centers that too have really strong relationships with the LGBTQ folks in their communities. They're a trusted source for information, for accurate information, for healthcare access, to navigate referrals to LGBTQ specific clinics and spaces to get, in the context of the vaccine, to go and get the vaccine in a space that they know will not be harmful or discriminatory in their process. Particularly for the trans community, this can be a concern with sharing documents like driver's licenses and things of that nature when going to get medical care. So if they can go to a trusted source, they can go and get their vaccine at the local LGBTQ community center, which a lot of these organizations have been doing. We find that has been successful for many of the LGBTQ organizations throughout the country in terms of trying to get folks in the community vaccinated.
Great, thank you. Stephen, your perspective on successes so far?
It's an interesting word, success, given the death count. And every day we're reading in the newspaper populations who are not only hesitant, but actively against the vaccine. And some of them have doctor and MDs behind their name. That gives me concern and pause. But there's some lessons that we've learned. And one of them comes from Mayor Omar Neal. You know him, Boris, former mayor of Tuskegee, Alabama, who moderates our town halls every Thursday night. And he says something like this. It goes like this: you need to make your friends before you need them. And that's my lesson, Boris, that the work in the barbershops started 10 years ago around health disparities. Then COVID hit. And what do we hear? That the disproportionate burden of COVID on populations of color was not because they were Black or Hispanic. It was because they suffered from underlying conditions, health disparities. So when we made our pivot, we recognized that we had already built some friendship around which we could actually bring the conversation into the humble setting of a barbershop and beauty salon. And after our first vaccine clinic on May 17th, here's our, what we call it, the geographic advantage, Boris. Our local paper is the Washington Post. And so when it was picked up in the Washington Post, it got picked up on the wires. And 48 hours later, we had a call from the White House. And long story short, they asked, could you scale this around the country? And for the young people out there, sometimes you just say yes. I had no idea. And now there's over 1,000 shops and salons around the country going through our rapid response training program. So timing matters. The pandemic actually pulled back the curtain on the underlying health conditions, the social determinants of health. We've been talking about these things, but now America writ large knows about them. And I think that opens the door for more progress moving forward, like bringing the flu vaccine into these settings, bringing other prevention screenings into settings like this. So we have friends that can also help our students and our other research partners moving forward.
Great, thank you, Stephen. Conde.
Dr. Lushniak and Dr. Thomas, you both talked a little bit about disparities, and I think it's clear that the pandemic has brought inequities to the forefront of public health. So I wanted to ask all of our panelists, how has your work addressed some of the racial and ethnic disparities of the COVID-19 pandemic? And let's start with Dr. Thomas.
Well, we started our work in the barbershops, believe it or not, on colorectal cancer screening. Now, Condi, if I can talk to you about a colonoscopy, I could probably talk to you about anything. And so the beautiful part about it was that we didn't, the barbers and stylists are not second-class health citizens. They make their places of business comfortable and welcoming for medical and public health professionals to come in and do their service. And here's the other plus, Condi. The colorectal cancer screening training we put them through was accepted by the state. And I have now 3 of them as certified community health workers. And that opened up a whole new possibility of a workforce, a public health workforce located in these settings out in the community. So I think that they're saying right now, Dr. T, Boris, that's the nickname they gave me. Are they going to give us the jab and leave us with obesity and cancer and hypertension? So now they're remembering all the work we did around the health disparities. Now they don't want these hospital systems to leave. And now the hospital systems in Maryland are calling, can I bring my mobile unit to your barbershop and salon? I can remember more than 18 months ago when I couldn't get a phone call back. So there's a moment we're in right now, and I'm hoping we can consolidate it and maintain relationship. I think our trustworthiness is on the line right now. If we abandon these communities once the surge threat is gone.
Thank you for sharing, Dr. Thomas. Dr. Bauer, how has your work at the Horowitz Center addressed some of the disparities of the pandemic?
Well, we focus on information disparities, which often are not that visible to people. So I think, our work in Frederick is a really great example of that. That came about because the Asian American Center of Frederick approached the Horowitz Center about partnering with them in the city of Frederick on the Advancing Health Literacy Grant. And their model, the Asian American Center of Frederick, it's based on community health workers as well. And so they have a whole cadre of community health workers who work across the city. And so our project there is built around those community health workers. And it's got multiple components to it. So it's making sure that the community health workers themselves have that accurate information to share with others. Because, while they do have that connection, that linguistic and cultural connection, they may not have easy access to a wide range of information resources themselves. So making sure that the community health workers have that information to share, that they're trained in really solid communication techniques that will help them share these messages. And then also doing the evaluation to show what difference that makes, because funders always want to know that. They want to know, are you making a difference with this work that you're doing in the community? So there's a very extensive evaluation component so that we can show that it does make a difference when you increase the amount of information that's available in people's preferred languages. I think, there have been a number of projects that have shown that Spanish language information has really increased, from government agencies and nonprofit organizations, but we have a long way to go in making information available in a much wider range of languages. And that's one of the things we're really trying to show with this project, is that it can make a difference when people not only have trusted sources, but also have information in their preferred languages.
Thank you, Dr. Bauer. Dr. Fish, how has your work addressed the social and mental health consequences of the pandemic?
Yeah, so I can talk about how earlier prior to the pandemic, we were working with Centerlink on a series of related projects specific to an online platform that they had been developing for supports for LGBTQ young people, where they could come, join a chat, it's synchronous, and kind of seek out facilitated services, support services, and connect with other LGBTQ young people. Well, the work that we had done there prior to the pandemic on feasibility, on acceptability, on facilitator strategies of that platform became really handy when everyone at the LGBTQ centers then had to switch to online services. So then we worked with Centerlink to try to develop some strategies to help them train some of the centers that were trying to push all of their services into online platforms. So a lot of these LGBTQ youth programs were doing most of their services in person. Youth were at home, did not have access to social support services, did not have access to the free therapy that they were receiving, did not have access to the peer support that they were receiving. And so these centers worked with Centerlink and used some of the things that we had developed and what we had learned in the process of their platform to be able to train the community-based staff to be able to take their services online on Zoom, on chat platforms, on servers like Discord and things of that nature. So that was one of the pieces that we were trying to support with that project. And I think that it ended up being really successful because what they did see is, particularly with some of these national platforms like Q Chat Space, which is the support program that I was mentioning, and things like Trevor Chat, which is a national chat resource for LGBTQ youth in crisis, they saw more than a 2- and 3-fold increase in the number of youth who were using those services, particularly in the early months of the pandemic. So that's some of the work that we did that I think, kind of what Dr. Thomas was talking about earlier, putting in the work beforehand, and then that work becomes really relevant in moments of crisis and need. So yeah.
Thank you, Dr. Fish. Dr. Lushniak.
Great. Let's sort of pursue this idea of Cynthia, you mentioned this whole idea of if the language spoken at home isn't English, the first language is not English, the methods used to reach groups, for example, not only through language, but let's say even through sort of differences, approaches on a cultural basis, right? What do people hear? What do they understand? What is it, what are the methodologies that are used out there in terms of health literacy to be able to be as effective as possible in getting the message, for example, about COVID, about vaccines to that population? What are we missing on the outreach and communication that we should have been doing from the beginning? And how do we take this all into account? Cynthia, why don't you start first, and we'll touch with the others.
Yeah, I mean, I think one of the things that we're committed to doing is diversifying our own teams. So I think, we really try and create a team structure that includes people from the populations that we're trying to reach through these projects. So Conde can certainly comment about some of the work we've been doing on social media in Spanish language. He's been leading a lot of that work. And, that's because we know that different populations prefer different channels, right? That's one of the things you do as a communicator is you don't just look at the message, but you look at where people are getting their information. It might not be where you as a public health professional are comfortable getting your information, but you need to follow that public health principle of going where people are and meeting them where they are. So we've been doing a lot in terms of Conde and Raya Griffiths and Leah Barnes, who are other members of our team. They've been doing a lot on the social media content, because what we heard early on from the local public health departments is that their Facebook pages were suddenly increasing in popularity, that they, even though they'd been on social media before, that people were really turning to Facebook as a place to get that information. There are other channels like WhatsApp, which is a closed messaging service, which is based on groups, people inviting each other to be in that. That's a little bit harder for us to penetrate in terms of delivering these messages. But I think we're, really trying to use as many channels as possible. So the community health workers are kind of the obvious. I mean, I think everybody thinks, well, let's have people from the community delivering these messages. But I think we shouldn't forget about the fact that, people of all language and cultural groups are on social media, and social media is where a lot of information circulates. So if we have a minute, I'd love Conde just to kind of comment on that from the work that she's been doing, if you don't mind.
Yeah, of course. I think as a native Spanish speaker, I definitely noticed there's a lack of content in other languages. So our team has been working really, really hard to translate all of our new content into Spanish, and also to coordinate with our partners to make sure that it reaches our target audience.
Great, thank you, Kande. Jessica, any perspective on this language, culture, and how we approach the idea of outreach and communication?
Yeah, I think this is absolutely critical. I know that when we were doing our focus groups, this is one of the first things that the centers brought up is can you provide these toolkits in other languages? Because in addition to serving the LGBTQ community, these centers are actually disproportionately serving elevated proportions of folks of color, folks who are immigrants, undocumented, and depending on where they are in the population, predominantly Spanish speaking or Hmong speaking, or even some indigenous languages that they're working with in these communities. And so obviously we can't translate into all of those different languages, but I think having the Spanish language translation has been really helpful to several of the centers that have been using the toolkits.
Great, Stephen.
Well, you know, I'm sitting here listening and I'm realizing I'm translating from medicalese to English. In other words, we're all speaking English, but the language of public health, even the language of medicine is problematic, and we have to translate that. Let me give you one example. Herd immunity. Raise your hand if you heard about herd immunity. All hands are going up. Well, when we use that word out in the community, you know what they said to us? Because we were using that word during Black History Month or early in the pandemic. We're not horses, Dr. Thomas. We're not cows. Aren't you watching the specials where they have us in chains looking back at slavery time? I thought that was quite insightful. When I tried to explain, no, herd immunity means, and I gave the really, really good public health definition. And you know what they said back to me? They said, well, that sounds like community immunity. And that has stuck. Then they made their own t-shirts that said community immunity, and that's been a big theme. So I think one of the lessons I've taken away is that we need to go into these communities seeking their wisdom, seeking their insight. And as a result, I think that, you know, science itself is being questioned in these settings. And I think we should be really concerned about that. So one of the things that we're doing is looking at different channels or formats. And one of the innovative formats we're working on right now is a graphic novel, a storybook. And this idea, again, came from the barbers themselves. Break it down, Dr. T, they said, just like you're doing it to a fifth grader. Step 1, step 2, step 3, and they're onto something. I think we need to listen to them and select channels and have them involved in the co-creation of the very messages that we want to disseminate in the to the community.
So Stephen just made the case for health literacy. Thank you, Stephen.
Well, you know, the other thing, if you go into these Black barbershops, I have no idea where people out there go, but Boris, you know, I've told you this more than once. No self-respecting Black barber or stylist will ever say, I'll get you in and out in 10 minutes. And it doesn't matter how much hair you have, you're going to be there half a day. And so we're looking at putting in flat screen TVs that will literally stream our YouTube content, our health literacy YouTube content with the help of Cynthia and her team right there in the shop for all to see, along with the other TVs that have all the sports games on and Judge Judy. Why can't public health be there just like the other content?
Yeah, I mean, that point about jargon, you know, it cuts across languages. I mean, of course, it exists in all languages, but, you know, if you are trying to take information from English to another language, any translator will tell you if it's written jargon free to start with, if it's actually in plain language when they're trying to put it, no matter what the format is, whether it's in print or it's audio visual or however it's delivered. It's better if the source material, whatever language it's in, is in plain language, because there are just a lot of concepts that don't, you know, as Stephen said, they don't work from everyday language, from medical language to everyday language, and they definitely don't work when you're crossing different cultural groups, because there are groups that might not even have terms for those concepts. And so you really do have to be very careful that whatever the original source material is, that it is written in plain language. And that is something that we have spent a tremendous amount of time in internally, making sure our teams are are using those plain language techniques, but then also sharing them out with all the partner organizations.
You know, Condi, could I follow up on that just a bit?
Of course.
You know, here's another silver lining of the pandemic: Zoom. Zoom existed before the pandemic. I've been doing more Zoom since the pandemic than ever. And you know what? Our community partners, they like it now. They've all been thrown into the deep end of the pool. And now nobody's getting $40 tickets on campus. So I think it can actually help our community be more engaged. And so this technology is a game changer moving forward. And I'm hoping that we, again, don't abandon it as a way of disseminating information.
Totally. Moving on to our final question, I wanted to ask all of our panelists and Dr. Lushniak as well. What is one thing that has surprised you while doing this work? And let's start with Dr. Thomas.
Well, the one thing that has surprised me, you know, was Dr. King used to say that the most segregated time in America was Sunday morning. And it may have been true there back in the 1960s, maybe less so today, but I do think when you go to get your personal care, your hair care, it may be another one of those most segregated times. And so the lesson for me is we need to find where people already feel that they have a sacred space of trust and be invited into that space to learn and to listen. And if I were to say to you, the faith community, everybody would agree. But I think COVID has really ushered in these non-traditional settings like the barbershop and salon. And I just sent to Boris earlier this morning at the National Governors Conference. Guess what? In the whole list of, here's how you reach people with trusted messages. And along the list is barbershops and beauty salons. So I would say to see something come from the margins to the mainstream, something so humble, I think it's a message to us. And if the hospital systems upon discharge shared with us, where do those people get their personal care? And how might we make those locations places where we're able to help individuals better comply with the discharge orders, better improve care coordination outside of the clinical setting, and again, extend our public health infrastructure out to those last mile communities.
Thank you, Dr. Thomas. Dr. Bauer?
I guess the thing that has surprised me is how much belief and opinion has really played a part in people's response to the pandemic, whether that's in their own personal circumstances and the decisions that they make, or in response to kind of the broader community sets of concerns. And I think that's something that as an academic community, I mean, this is an event for the Alumni Association, so that means that everyone, you know, has spent some time at this institution and, you know, has been exposed to a range of ideas. I think that's something that we should all kind of give pause to and really think carefully about. There are lots of ways of knowing the world, and right, we've been talking about some of that. And, you know, there are many reasons to value different ways of knowing the world. But when it comes to making, you know, these kinds of very critical health decisions, I think we should, you know, really think carefully about the role of belief and opinion versus information that has been tested and verified and can be challenged and retested. And I think that's really what has surprised me the most is how many times I have listened to different reports where people are bringing information that can be independently, objectively verified and presented to people, and their response is, I don't believe it. There's no other answer, but they just say, I don't believe it. And so I think this reliance on belief and opinion is something that we all ought to reflect on, because I think it's potentially, it's going to create some longer term implications for public health, not just for COVID, but for the way public health rolls out. And, you know, I do think the comment that we saw in chat, I do want to remark on that, because I think it is important, again, to make sure that you understand what the information sources are, understand the kind of information that's contained there, because the information there about the VAERS system isn't accurate. And so I think we really need to make sure that people are verifying that information and only sharing accurate information with others.
Thank you so much, Dr. Bauer. Dr. Fish?
Yeah, I honestly, for me, Cynthia, you summed that up so beautifully. I feel I feel the same way. I think maybe just because we've spent so much time together over the last 6 months, but just this pitting belief and opinion against at equal weight as fact or as science and information that can be verifiable and tested and retested and replicated. And compelling science at that, in terms of the numbers, is just continues to be something that it's just a remarkable thing to witness, at the expense of human life, at the expense of quality of life. And so that just, you know, every day in these meetings, when we're talking about the numbers, when we're talking about the science, and some of the things that we're seeing and the things that we're reading are related to folks' beliefs and opinions, it just continues to just kind of, it's just surprising, and continues to be so.
Totally. Thank you, Dr. Fish. Dr. Lushniak?
You know, it's interesting. When I kind of reflect on this, I actually go back further in my career. Prior to being the dean, as mentioned, I was what I refer to as a public health practitioner. 16 years at CDC, 6 years at the FDA, and 5 years in the Office of the U.S. Surgeon General. In fact, the last 10 years of my career in uniform, Public Health Service Commission Corps uniform, was spent preparing for this type of event, right? We always knew a pandemic would happen. We just never knew when. Right. And if there were any surprises, I kind of reflect on this idea of how we used to prepare. Right. We used to some extent, go through tabletop exercises. And oftentimes that would be with political leadership. Right. So you would take the leadership of Health and Human Services, maybe the leadership of the Department of Defense, other entities in the U.S. government, and you would sort of do this tabletop exercise, putting in inserts, right? And the inserts were always okay, so we have a disease outbreak, this is what's happening. And they would all sit around and discuss what needs to get done. And then we throw in an insert that would kind of, you know, screw things up, for want of a better term, right? It'd be make them go back to the drawing board. What I guess I'm most surprised at is that many of the inserts that we have experienced in real life situations in this pandemic were to some extent never ever practiced, because we never thought they would happen. And bad on us from a planning perspective, right? The issue of, let's talk about it, right? The politicization of public health recommendations, right? Masks or no masks, vaccines or no vaccines. Is it real or is it not? You know, they were there, but never to this extent that was, you know, in such a polarized society. Even the issue of the multiple variants that are happening right now. We always introduce sort of the variants, but now this whole idea of a coronavirus, you know, kind of taking control at times, and to a large extent, we almost have to react after the fact, right? You know, most of our tabletops were all about pandemic influenza. So all of a sudden we have this brand new virus. So I guess if there's anything that I take away in terms of what am I surprised over, is the number of surprises we've had in the midst of all this, which goes to prove that nature, right, is still in control, right? This little virus wants to continue to exist, and we want to figure out ways so it doesn't affect our health and our lives. And that's what we're shooting for. You know, when we talk about sort of things, and I do appreciate the comment on the vaccine adverse event reporting system, right? And part of it goes back to what Cynthia said, is we have to understand what data is out there, right? And VAERS in itself, right, as a database, this vaccine adverse event reporting system, always says, and this is almost a direct quote, I believe, that it is, you know, this is a reporting system. The information that's out there, it's not hidden, but it is oftentimes based on incomplete, inaccurate, coincidental, and unverified information. So we have to be careful of where we take information and say, aha, I just found out that this is the truth. We have to determine there needs to be reaction to things that are reported on the vaccine reporting system. But at the same time, one needs to investigate, right? Overall, as I mentioned, 440 million vaccine doses. Okay, we do expect adverse events to occur. Nobody's denying that those are not occurring. Are they deaths? I don't know how many at this point, but we need to be able, from a public health aspect, not just ignore, but verify to a large extent. That's the reason these reporting systems are out there, to denote the issue, do we have a problem or not, right? And to react to that. But that's a great question, Conde. Thank you. How about you, Conde? What surprised you during this whole pandemic from your perspective?
I think something that surprised me back in May when I started on this project, and then something that still surprises me, is that access is still a barrier for many people. A lot of our partners have shared that people are still concerned about the cost of the vaccines. They're concerned about insurance requirements, ID requirements, or they don't have reliable transportation to get to a vaccine appointment, or they can't afford to take up work to go to an appointment. So I think increasing vaccine confidence is really important, but I think addressing these access barriers is too.
Great. We have any more questions coming up? Troy, I see you're asking, if virus is inaccurate, how many vaccine-induced deaths and injuries have there been? From my perspective the reports go into VAERS. That's the reporting scheme. The real question is how many have been verified? How many have been in fact determined? Don't forget, VAERS is not causation. It's a relationship of a vaccine followed by some sort of adverse event. The reality is that at this point in time, the numbers, even in VAERS as a reporting system, are rather low compared to the general population getting the vaccine. I don't know the answer. I don't think anybody at this point knows the exact number, if there are deaths and how many there are. We know in general that the reporting system, although inaccurate at times, not fully accurate, is the system that's always been utilized, and to some extent, it'll take those further investigations. Don't forget, there were clinical trials at the beginning of this with the vaccine, ongoing clinical trials, right, in various numbers of individuals, and now the numbers keep growing larger in terms of vaccinated individuals. So all that becomes part of the data gathering source at this point in time. Any comments from any of the panelists regarding accuracy of data that's out there and how we interpret that data? Panelists?
Well, I was going to say that, one of the things I always remind people is that the data that we have, the population data that we have on adults in this country indicate that people's numeracy skills are actually much lower than their literacy skills. So if we're concerned about people's comprehension of written information, we have to be even more concerned about the way that numerical information is presented to people. Any information that's presented as a decimal or a fraction or a percent, which a lot of the COVID information has been presented that way, is really challenging, even for people with a statistics background, right? You think, oh, well, people trained in math, statistics, epidemiology, no, it really depends on the way information is presented to people. And so I think that we need to always exercise caution, right? I think, one of the things that often gets pitted against each other is, you have one group of people claiming they have accurate information, then everything else has to be inaccurate. If you are in the business of science, everybody is a skeptic, right? Our job is to be skeptical of all information and to investigate that thoroughly and test it out and to only confirm those things that can be confirmed. So I think, if we could be more, looping back to our first question about success, where I'd like to have more success is in explaining how science as a process works, because I actually think that could be reassuring to people. I think science is a process of knowing certain kinds of information that you can test out and that you can be transparent about and show people why something worked or didn't work. And I think if we could make some headway on science as a way of knowing, and that could actually bring some transparency to the information that we have about COVID or any other health issue, I think that would be a huge step forward. And numbers are just a part of that. In terms of being able to understand the information that science produces. But it loops back to what Stephen says. Unfortunately, we get caught up in our own jargon too often. And that's what we're trying to remedy with health literacy approaches.
You know, Cynthia, there's something Condi said that just struck me. Here we are 18 plus months into this pandemic. And Condi, if I heard you right, some of your community partners' hesitancy is about how much does the vaccine cost? Now, the vaccine has been free from the very beginning. That's our failure. Look in the mirror, public health. How is it that we have people out there wondering if the vaccine is going to cost them money and therefore they're hesitant? Is there some group out there charging them that we don't know about? Or have we simply not gotten to them? So that gives me pause about how much work we have to do on the very simple things. And if we underestimate the politicalization, I think we'll get blindsided. I mean, I remember when at 7 o'clock at night, people were out on balconies clapping and pots and pans. And don't you remember that? The military flyovers for the health professionals. How have we gone from the health professionals being heroes to villains, people fighting them in the hospitals in a matter of weeks? So it takes courage to do this work and to do it well and to speak the truth that you find when you go out in these communities. And I think we need to prepare this generation for what might be a future, Boris, where the politicalization continues to be a backdrop against which we really have not. I haven't seen in my career. I'd be curious if anyone else has seen it, but it is kind of unprecedented, well-funded and organized. And social media clearly was not around in any of the past pandemics. So that adds another complicating factor. So I think we're up against some real challenges that should make us be more humble about what we know and what we don't know, and be willing to be open to really doing things differently.
Well, and I think Carol's comment about how much information is being shared with the public, I think that's also part of our responsibility as public health professionals, is to constantly push for information transparency from all sources. That's something that we can advocate for, right? We should be on the side of open information sharing. That's a value of science, is open information sharing. And so I think if people have questions that they feel are not being answered, or there's information that's not available, we should be champions of answering those questions and making that information available.
Great. And on that note, do want to send a special thank you out to Caitlin Waite, who's also been out there assisting in this whole program. Conde, this has been a great opportunity for me to co-host along with you. So thank you again for your professionalism and your approach on all this. And any final words, Conde, from what you've learned tonight?
Just thank you so much for having me, and thank you to the panelists for sharing your successes and challenges. Yeah, thank you everyone for attending as well.
Great. Angela, off to you.
Yeah, thank you, everyone. Thank you to Boris and Jess and Stephen and Cynthia and Conde. We really appreciate all of your time, and thank you for all of you tuning in this evening. We will send out the recording later this week. Have a great night.
Bye-bye. Be safe out there. Keep your mask close. We're not over yet.